Last talk of this session, talking about balloon mitral valvuloplasty. Dr. Raghava Raju is going to give us an overview of the different techniques and tips and tricks.
Good afternoon. Respected chairman and the other panelists and the colleagues. The topic is percutaneous mitral balloon valvuloplasty tips and tricks. And we all know that despite all the merits of balloon mitral commissurotomy, it is not without potential problems and complications or difficulties during the procedure. Now, my talk involves, the purpose of this review is to reiterate some of the technical precautions and discuss some of the potential complications which can lead to the failure of the procedure, and I'll try to provide some of the tips while going through some of my few slides. So the vital component of balloon mitral commissurotomy is the transeptal puncture and transeptal catheterization. In this talk, it is beyond this presentation because it involves a lot of discussion. I presume that the operator has mastered the transeptal catheterization and access the LA wire, left atrium, and the LA wire is right across, and the balloon is prepared, appropriate balloon catheter is chosen for performing the balloon mitral commissurotomy. So the topic mainly evolves around the practical aspects. Mainly when performing the procedure, sometimes we may encounter resistance at the groin side, difficulty in maneuvering the balloon catheter across the atrial septum, and placement of the balloon catheter in the left atrium and maneuvering or navigating the catheter across the stenotic mitral valve. And in the end, some of the balloon impressions may give a clue to the possible complication of mitral regurgitation. So I'll go through one after another. The first thing is that the LA wire is across the stainless steel wire, 0.25, and when we try to advance over the wire, majority of the times the catheter can be advanced smoothly without any resistance. Occasionally, when we find that the access to the femoral vein is with less angulation, and if the initial axis of the femoral vein is parallel to the skin or less than 30 degrees, what will happen is there will be creation of long subcutaneous tunnel. You can see here that this long subcutaneous tunnel can sometimes offer a lot of resistance. And to avoid this, the most important thing is initially whenever we access the femoral vein for the technique of mitral commissurotomy, it's very important to remember the fact that access the femoral vein in a vertical fashion and shorten the distance of the subcutaneous tunnel or the tissues which the catheter has to traverse. Despite taking all the precautions, sometimes we find that there is a difficulty in tracking the balloon over the wire. Now, what we can do in such a scenario, you can dilate the track again with a 14 French dilator, or dilate the subcutaneous tissue track with an arterial forceps up to the level of the femoral vein. And sometimes this may not work, and occasionally we found that if this track is dilated with a peripheral balloon, a 6 millimeter peripheral balloon from the subcutaneous tissue to the entry of the femoral vein, it can help. Very rarely you need a 14 French sheath in the femoral vein to advance the mitral commissurotomy balloon. This is very unusual. This scenario is very unusual. Apart from that, the another resistance we find at the groin site is that when we advance the balloon catheter parallel to the skin or the tissues, you encounter a resistance because the catheter cannot enter the femoral vein entry point. So in that scenario, you have to make the catheter a little vertical, almost perpendicular to the entry site, and advance, and this catheter tracks the wire, easily enters the LA, the lumen, and then you make it horizontal so that you can easily advance the catheter. So these couple of issues are very important to access the vein as vertically as possible. And when you are advancing the mitral commissurotomy catheter, try to, if you find any resistance, try to enter the femoral vein lumen vertically and then make it parallel to traverse subsequently the vein. Another difficulty is not unusual to that we find resistance at the septum, especially if the transseptal puncture is inappropriate or the lower level, or you have punctured the interatrial septum at the thicker portion, there is bound to be some difficulty in tracking the catheter across the mitral valve. And another reason maybe there is the septal dilatation. Your septal dilatation is inadequate with the 12 French dilator, and you may need a 14 French dilator to enlarge the size of the septal puncture. So what we can do is, if you force the catheter, mind you, when you force the catheter, you can deflect the interatrial septum and can cause pain and discomfort in the chest. And sometimes the forcing the catheter can cause a stretch on the IVC and causes the abdominal discomfort. Any amount of force here is likely to cause complications. Never force the catheter. Bring down the catheter and advance and in a clockwise torque and a screwdriver maneuver to overcome the septal resistance. It helps sometimes. Sometimes what we can do is that if this maneuver fails, you have to redilate with the 14 French dilator, and even if that doesn't work, you may need to dilate the interatrial septum with a balloon. Typically, the PTCA balloon can be used. Here is a case where we couldn't cross with even after the 14 French dilator, and then we have advanced the Mullin sheath and placed the PTCA wire along the side of the LA wire, and then dilated with the 5 millimeter balloon. You can see that how thick is the septum. So if you dilate only with the dilator, it's impossible to traverse this interatrial septum. So this technique of dilatation of the septum with the PTCA balloon will help you in overcoming the resistance at the septal level. Now, once you cross the interlateral septum and maneuver the balloon into the left atrium, the most important thing is the initial placement of the catheter should be as deep as possible, and see that the tip of the balloon is around 7 o'clock in the frontal plane. If you place this catheter deeper, this will help that when you advance the spring stylet, this catheter will not flip into the left atrium. If you are not too deep, when you advance the stylet, it flips into the left atrial appendage. So if you want to avoid the left atrial appendage, is always position your catheter deeper in the LA cavity. And at the same time, if you're deeper in the LA cavity, this is very unlikely that it will go into the pulmonary vein. And not only that, if your catheter is quite deep in the LA cavity, and when you advance the spring stylet, the only maneuver to cross the stenotic mitral valve is gently pulling back, so that you need not push the catheter forward and withdraw the catheter. So one of the main important point is to position the catheter initially deeper in the left atrial cavity. So this positioning of the catheter will help in avoiding the left atrial appendage, especially if the patient has a left atrial clot and you're forced to do the mitral commissurotomy for some reason, the patient is not fit for the surgical intervention. And another issue is that it's not uncommon to have the catheter and entrapment by the atrial septum, especially when you are using a recycled balloon catheter which loses its coating, and then this causes a lot of friction at the atrial septum. So if the catheter is entrapped by the septum, however much you push, it is going to form a loop in the right atrium, and sometimes it may prolapse into the right atrium, and then you may lose access into the axis of the left atrium. So what can we do? And this entrapment is usually due to the thick and the tough septum, and one way of overcoming this is advance the stylate, and once you advance the stylate, you make a clockwise rotation. This clockwise rotation makes the catheter perpendicular to the interatrial septal plane, and then when it is perpendicular, it's much easier to advance. Once you advance the catheter, give a counterclockwise rotation to reach the anterior part of the left atrium and the mitral valve. If this fails, sorry. If this fails, you have to remove the balloon and dilate the interatrial septum, or sometimes you advance the coil tip guide wire and to facilitate for the deeper placement of the left atrium. And once you sometimes when you are manipulating this balloon mitral catheter, sometimes it can go into the pulmonary vein, and this can be recognized by the lack of free motion of the distal catheter when attempting to advance or the twist or untwist the catheter. So what you have to do is pull back the catheter along with the stylate into the left atrial cavity, and then you give a counterclockwise, because the pulmonary veins are posterior, and if you give a counterclockwise rotation, you can enter again the anterior part of the left atrial cavity where the mitral valve is located. And then you can align the axis of the catheter towards the mitral orifice LV apex axis. Coming to the most difficult or the technically important aspects is crossing the mitral valve. There are several ways of crossing. The most important thing is that the direct crossing, once you position the deeper placement of the balloon catheter, you give a counterclock twist to the stylate so that it points anteriorly, and then once you reach the mitral valve orifice, the catheter tip moves like a woodpecker motion up and down, and when in the diastole it moves downward, then simultaneously withdraw the stylate and advance the catheter. This is the commonest way of entering the LV or crossing the mitral valve. Sometimes if the transeptal puncture is inappropriate, or if the septal puncture is higher or quite medial, it is difficult to manipulate the catheter into the axis of the mitral and the left ventricular apex. So in that situation, you have to give a counterclockwise or the clockwise twist to the stylate, and then take the left atrial posterior wall support and advance only the catheter. The third way of is third technique is sliding the catheter. balloon is first directed towards the mitral valve by twisting the J stylet with a counterclockwise loop. Then balloon is made more more flexible by withdrawing the stylet, and this makes the balloon very flexible and keeps moving at the movement of the mitral valve. And once the catheter is at the level of the mitral leaflets, then you advance only the catheter by fixing the stylet. So in this technique, you are keeping the stylet fixed, and then with a counterclockwise twist to the stylet, you are advancing the balloon catheter only. And in the another technique is vertical method, where you take the help of the roof of the left atrium, you position the catheter deeper and advance the stylet. When it is at the level of the mitral valve orifice, it moves up and down, and then in this scenario, once you withdraw the stylet only, the catheter tip falls into the balloon, falls into the left ventricular cavity. Sometimes, despite all these maneuvers, if it fails to cross, you are left with another choice, is shaping the stylet. In a very large left atrium, you need to make a bigger curve of the J stylet and then manipulate the catheter. If the LA is small, or if it is the inappropriate puncture, then you may need to tighten the curve by modifying the curve. Very rarely that you can cross the mitral valve by a over-the-wire technique, making a AV loop. Despite all the methods, if you fail, what we can do is you put the Mullin sheath in the left atrium once again and advance create a loop, AV loop, by advancing a through-to wire and then snare it in the left ventricle or in the aorta and making a AV loop and advance the catheter. Most important thing is when you make the AV loop and advance the catheter, you see that your balloon catheter is not going through some of the chordae. If you fail to notice this, you can create a rupture of the chordae and then severe mitral regurgitation. It's very important when you advance the balloon mitral catheter over the wire to be sure that your wire haven't traversed one of these chordae. And coming to once you are in the LV, the most important thing is to stay away from the caudal structure. This can be assessed by inflating the distal part of the balloon and making an accordion maneuver. If the balloon catheter moves freely to and fro, we are sure that we are not entangled in any of the chordae. And it's not uncommon that the people miss the significance of valvular fusion by the echocardiography, by the transthoracic or transesophageal echocardiography, and you may notice that the patient has valvular fusion while performing the balloon mitral commissurotomy because some of these balloon dilatations can give impressions of subvalvular disease. This can be detected by, number one, when you're performing the accordion maneuver. If it is not free, you know that there is a significant subvalvular fusion. Once you notice the significant subvalvular fusion, you have to decide that you may need to undersize the catheter. Or sometimes when you have inflated the distal balloon, you find that there is indentation on the balloon undersurface or the superior surface. It suggests that the subvalvular fusion is more than what is assessed by the echocardiography. And another issue is that whenever the patient has a subvalvular fusion, very severe, when you're advancing the balloon catheter from the stenotic mitral valve, sometimes we notice that the balloon enters the funnel, but when you push the catheter, it makes very slow progression, and sometimes we may not be able to reach the apex. In the process that it's, as you found that it's difficult to access the LV, and you may be in a hurry to inflate the balloon, because with the balloon across and the fall in the pressures, you may try to inflate the balloon and you can end up in a disaster. Best thing is to, in this scenario, to come out and reassess that the patient may be having a subvalvular fusion severe, and it's not uncommon to send such patients for surgical commissurotomy. And sometimes when you are doing the accordion maneuver, when you are pulling the balloon, inflated balloon, if there is significant resistance and a cogwheel resistance and a ratchet field, and this is a clear indication that the patient has a subvalvular fusion, either you postpone the procedure, avoid the procedure, or undersize the balloon. And coming to finally, one of the most dreaded complication is that the failure to deflate. And then one of the personal experience that when we have inflated the balloon right across the mitral valve, and tried to deflate, and we couldn't deflate, and then the patient had S attack and zero blood pressure, and then the patient have developed bradycardia arrest. And what to do? There is hardly any algorithm, or you can do very little. In this scenario, what you have to do is reflexively pull with the force. You don't have time to puncture the balloon by advancing a blunt tip of the LA wire through the inflation port. You will not have enough time to do all those maneuvers. Sometimes you will be forced to withdraw the balloon, and then even if the patient develops severe MR, you can always send for surgery. And this is another case example where the authors have tried to pull the catheter. They could pull from the mitral annulus to the mitral annulus to the LA, and then they advanced the blunt tip of the LA wire through the inflation port, could perforate the balloon and then deflate. So these are some of the important complications. And then at the end of these tips, and most important thing is to know the safety rules, and I hope that some of these pitfalls and then the solutions will help the new operators. With this, I'll conclude my topic. Thank you very much.